Okay. I will try to briefly summarize the malformations of cortical development. Why we are talking about this challenging topic is that the diagnosis is challenging in these babies with malformations of the cortical development. And these malformations are a significant cause of neurological morbidity. They are the cause of childhood epilepsy in more than half of the epilepsy polyclinics. And also the babies born with malformations of the cortical development, around 75% of them will have childhood and adulthood epilepsy. And also these disorders are associated with important cognitive deficits involving autism and the cerebral palsy in the babies. The problem, the challenging diagnosis is that the fetal brain has a smooth surface until up to 20 to 22 weeks because the developmental process of the cortex continues throughout the whole gestation. So when one is examining a brain prior to 20 weeks, one sees a smooth surface of the brain, but after the 20 weeks to 22 weeks, with the cerebral cortex formation, we see more we see the sulci and the gyrus appearing on the brain surface. What happens during the development of the cerebral cortex is that there are three overlapping stages. The neurons which originate at the periventricular zone around the 7 to 8 weeks of pregnancy begin to proliferate and migrate from this area. This proliferation and the migration of the neurons from the periventricular zone towards the cortex makes the architecture of the cerebral cortex. But this is not only made by the proliferation and migration. Following these steps, the cortex should undergo proper organization. So any factor, such as some genetic factors, any infectious factors, or any vascular factors, may cause an arrest or under or overdevelopment in these stages. And these under or overdevelopment or arrest of the development during the cerebral cortex formation leads to the malformations of the cortical development. They are seen rarely, and the estimated prevalence is thought to be 1 in 2,500. There are many complex classification systems for that, but the most recent and the most simplified classification system has been updated in 2012. As you see, it's called the Barkovich classification. First of all, before going into the details of these problems, we should know the underlying mechanism causing these pathologies. If there is abnormal proliferation or abnormal apoptosis, this lecture has been given previous to me by Dr. Sertaç Esin, the microcephalies or megalencephalies may emerge. If there is any problem regarding the neuronal migration, if the neurons do not migrate properly, there may be lysencephaly, band heterotopia, cobblestone complex, nodular heterotopia. And if there is a problem in the cortical organization, we may have some increased gyrus formation, which is called the polymicrogyria. So why we have to diagnose so rare problems is important. It's important because we have to counsel the risk to family members, because with the use of the genetics and with the increased use of the genetics in our clinics, we see more and more genetic problems associated with these malformations of cortical development. For example, this case with unilateral polymicrogyria was presented to the clinic with hemiparesis and mild cognitive delay, and the array analysis revealed a microdeletion in 22q11. So these patients having these developmental problems should be karyotyped, and also they should take good genetic counseling For this polymicrogyria, you see there are many chromosomal problems associated with polymicrogyria, and there are many monogenic problems associated with these problems. Regarding the lysencephaly, in this study, it has been shown in 811 patients, 81% of the patients were shown to have gene defects, 17 type of gene defects in lysencephaly. The determination of these genetic mutations is important, especially when you are giving the genetic counseling and also you are offering other reproductive choices for the next coming pregnancies and also for the recurrence risk. Up to now, there has been around 200 genes which exhibit some mutations in the major cortical maldevelopment of the cortical development. And we have some mutation panels for this. And the mutation panels usually involve 30 to 35 genes in case of diagnosis of cortical malformations. So what are the hints for the prenatal diagnosis? How should we get suspicious of these problems on the fetal ultrasound? Most important part of the brain examination, apart from the detailed examination after the 20 weeks, in every examination, an obstetrician should evaluate the size of the brain, if it is reduced, increased, or normal. And also, the obstetrician should evaluate the folding pattern of the brain. It will give so much information regarding the cortical development. But on the ultrasound, since I said before, the standard second trimester ultrasound gives limited diagnosis due to the ongoing development, and the limited evaluation of the peripheral structures of the brain. These are the disadvantages of the ultrasound examination for fetal cortical evaluation. We can get suspicious of any fetal cortical malformation if we find any evidence of deviation from normal pattern. We just don't go directly to the diagnosis. We just should search for the evidence of any deviation from the normal pattern of fetal brain development in every examination of the baby. So in this study, which is one of the most extensive studies, it has been shown that the most prominent ultrasound findings were abnormally overdeveloped gyri and sulci for the gestational age, delay in sulcation, and abnormally thin cortex. These were the predominant three findings in babies with malformations of cortical development. And also you may see some abnormally wide and broad sulci. You may see some bulging into the lateral ventricle. You may detect some clefts, and you may detect also some intraparenchymal echogenic nodules. So these signs are very, very important. We will go through this abnormal sulcal pattern. Every obstetrician should know about the sulcal pattern during the going gestational ages. Here you see at 32 weeks on the left, the sylvian fissure is underdeveloped. At 32 weeks, you should have a more prominent sylvian fissure. So there is a problem there, and you see some isolated ventriculomegaly. And on the right image, you see the increased subarachnoid space, very thin cortex, very small brain, and you see the increased gyrus in the ultrasound. So just we should emphasize, we should look at the brain size and also the brain folding pattern during every ultrasound examination. You may see some clefts, they are very easy to see, but sometimes you can also recognize in some heterotopia cases, for example, or some infectious problems, you may see some nodules in the brain parenchyma and some periventricular, nodules in the periventricular margins. So does MRI add when you suspect of any problem on the ultrasound for the diagnosis of the MCD? Of course, it's for the soft tissues, it yields more anatomic information and better evaluation of especially the sulci and the gyrus. There is an important study for that in 2011, Barkovich, whose classification system we are using now, was also involved in this trial. They compared the postnatal MRI imaging of the babies with the fetal MRI imaging. And these images were reviewed by pediatric neuroradiologists. And in this study showed that for polymicrogyria, there is 85% sensitivity, but with 100% specificity. For schizencephaly, 100% sensitivity with 100% specificity. But when you go for heterotopia, the sensitivity suddenly, dramatically drops to 67%. And even if you go below 24 weeks for the fetal MRI for diagnosis of heterotopia, your sensitivity falls down to 44%. So MRI is not very sensitive for all types of MCDs, but it has high specificity for all types of MCDs, but it has good specificity. So in suspicion of MCDs on the fetal ultrasound, postnatal the MRI imaging may help, but it is more helpful for polymicrogyria and schizencephaly, but not so helpful for heterotopia. If you suspect of heterotopia, for example, you should proceed with the MRI maybe after 24 weeks because the sensitivity increases thereafter. So the brain fissure development is important, as I said. On the ultrasound, you always see these fissures. It's just obvious there, but you should look at them. So the sylvian fissure, the calcarine fissure, and the parieto-occipital sulcus, they appear early on the ultrasound. Being aware of them and being aware of their development, you can monitorize your patient's baby's fetal cortical development by monitoring this fissure and sulcus development on the ultrasound. At 18 weeks, you start to see the sylvian fissure unfolding. At 20 to 23 weeks, you see the parieto-occipital fissures and callosal sulcus on the ultrasound. And as the pregnancy advances, you get the calcarine, central, the other sulci appear as the pregnancy proceeds. So we know which sulci, where are they when we look at the ultrasound. For example, the parieto-occipital sulcus is one of the most easiest sulcus to be examined because it's just at the level of the lateral ventricle measurement. It's usually recommended to measure the atrial width at the level of the lateral ventricle at the parieto-occipital sulcus level. So the parieto-occipital sulcus is just on the axial plane, just a little bit cephalate to the transthalamic plane. And the sylvian fissure just appears on the axial transthalamic plane. So if you know where to look, you can see these fissures, and also you can evaluate the development of these fissures. The sylvian fissure unfolding gets very prominent around the 25 weeks, and there are some grading systems for that. We know how they develop. And if you look at the 25 weeks, you should see a rectangular shape for the sylvian fissure. This is called the operculization. But if you are at the 25 weeks and if you don't see this operculization, you should get suspicious of this any cortical development. Here is the video. It's there. We are at the transthalamic plane, and on the transthalamic plane, here you see the sylvian fissure, operculization, the rectangular shape at the 25 weeks. In this baby, you can assure yourself the baby's cortical development is going all right, just looking at this fissural development. For the parieto-occipital fissure, it first appears around 16 to 18 weeks. And when the pregnancy goes further, around 22 weeks, as you see here, this parieto-occipital sulcus gets deeper. And when you are evaluating a baby on the ultrasound, when you are looking at the ventricle, it's very easy also to assess the development of the parieto-occipital sulcus, just superior to the lateral ventricle. So as you see here, it gets more and more deeper as the pregnancy proceeds. Here, a parieto-occipital sulcus getting deeper at the 28 weeks. Also, you may see the calcarine fissure at the level of the occipital level. When you're examining the cerebellum, you may see this fissure there. But the most commonly recommended fissures are the sylvian and the parieto-occipital fissures to be evaluated on the ultrasound. But it's also important to emphasize that the convexity sulcus, which are seen just at the periphery of the brain, just lateral to the sylvian fissure, appear rather late. You should expect to see them around 28 weeks. If there is any problem, if you think at around 28 weeks, you cannot detect these convexity sulcus lateral to the sylvian fissure, you don't see this deepening structures of the sulcus, you should get suspicious again of any cortical maldevelopment. If there is any delay in sulcation, you may see abnormally thin cortex, irregular ventricular margins, and increased subarachnoid space. It's called the lissencephaly. I won't go into the details for the lissencephaly types, but it's important to note that they're associated with important genetic problems. As you see, this lissencephaly type 1, there is the isolated ventriculomegaly, there is underdevelopment of the sylvian fissure here, and there is underdevelopment of the parieto-occipital fissure here. In lissencephaly type 2, there is underdevelopment in the fissures, but also you see some nodules because it's associated with the abnormal over migration in the neurons when compared with the lissencephaly type 1, which is associated with abnormally under migration of the neurons. And always look at the periphery of the cortex. If the periphery is very smooth after 20 to 24 weeks, get suspicious of this lissencephaly, and also look at this space between the cortex and the calvarium, which is the subarachnoid space. Small brain causes increased subarachnoid space when you are evaluating the brain. So you may see increased sulcation. Sorry, I have gone. Buradan çıktı da. Hayır, buraya gitti oynarken. Okay.
Ne istiyorsun?
Sorry, I'm back. Am I sharing the screen now?
Slide'larına mı gideceğim?
Olus, you made
Okay.
a presentation and then you made it very nicely. Thank you very much for this. You know, this is the technical part, happens sometimes. But let me know whether or not you would like to continue with the next presentation because you've been very busy. Yeah, just make it enjoyable. Then I'm asking to all participants to make a raise hand if you like to hear brain vein, stroke, hemorrhage, cyst, and tumor, and a hypotension as a last, talk. And then I would like to see the raise hand if you like to continue with the last topic. In the meantime, Olus is trying to share his presentation. At the moment 29 and getting more, I don't know. I need more raise hand. I need more raised hand if you like to continue with the last topic. Okay. Olus, you've done a great, things about the cortical malformation. It's very well understood. Don't be panic. You made it a great job. Then I know the chat, everyone, was enjoying very much with your presentation on cortical information because it's a very tricky issue. Therefore, now I see the more hands, but not more than getting 38 raise hand. I need more. But I can understand you because we need to make the more postgraduate courses. Therefore, we shouldn't, we shouldn't say everything in one time. Then we need your presentation for the next time. Okay, then therefore, everyone is enjoying. Therefore, if I do have you for the next course, then I'll have more participants. then I can see that. Still, you would like to share your last presentation? Welcome.
Okay, I can, but if any technical problems, please, I'm really sorry about it.
Yeah, just jump on your next presentation because everyone would like to hear you. I can see.
Okay, am I there? Am I sharing my screen now?
Not yet. Please do so.
Okay.
All right. But yeah, Guillermo, you've done it finally. You know, even you can join us with your voice. You are more than welcome. Just let me, yeah, Olus, your slide is working. Just let me introduce Guillermo Azimanti. He's one of the leading experts in the world on fetal brain 2. Then very good to see him, and I'm very happy to see him.
Thank you.
Carry on with your presentation.
Okay, I hope I will finish it. Okay, thank you very much. Now we will again discuss some rare events, but when we see them, since they are very rare events, we are just giving the lecture here to learn about it, and when we see it, we can diagnose it. So the Galen vein aneurysm, as you see here, its prevalence is rare. It's seen in 1 in 25,000 births. And in the ultrasound diagnosis, you can see the supratentorial midline translucent cyst with active arteriovenous flow within the cyst demonstrated by the color Doppler. And during this examination, you should also search for the signs of congestive heart failure if you get suspicious of the vein of Galen aneurysm, because since it's an arteriovenous malformation, it leads to high output heart failure. So you can see some signs of congestive heart failure, such as the dilated heart, tricuspid regurgitation, and when you suspect of any midline translucent cyst in your examination, just go and put your Doppler on to see if there is any flow inside. And if you are suspicious of the vein of Galen aneurysm, if you see any flow inside, you should go and examine the heart to look for the signs of congestive heart failure. And some babies may present rather late, and you may also see a fetus with hydrops fetalis, which presents rather late after the onset of the congestive heart failure. The important thing, the associations, the incidence of the chromosomal abnormalities or genetic syndromes is not increased in case of the vein of Galen aneurysm. But when you detect any vein of Galen aneurysm, you should go for an ultrasonographic examination, because this might have led to some ischemia or might have caused leukomalacia. So you should exclude the secondary brain lesions. As I emphasized before, on echocardiography, you should check the signs for the congestive heart failure. And you should also order the follow-up scans, organize the follow-up scans every 1 week to determine the time of delivery. And the determination for the time of delivery mostly depends on the risk of the congestive heart failure. If you see developing congestive heart failure, then you might opt to go for delivery of the baby prematurely. Usually, if there is no congestive heart failure or if there is no progression in the vein of Galen aneurysm, you go to the delivery around 38 weeks by cesarean section, and you give the baby to the pediatric surgeons, neurologists, intervention radiologists for the embolization of this arteriovenous malformation. To give some idea about the prognosis, this is the most extensive literature data. It has 49 babies results, retrospective study coming from Israel. The baby is diagnosed prenatally and managed at 2 centers over almost 20-year period. We can say that around 10% of the vein of Galen aneurysms may progress between diagnosis and delivery. In this series, 5 out of 49 progressed. Look at these cases at 31 weeks diagnosis, the progression at 32 weeks. The other 132 progressed at 36 weeks. That's why we should regularly check these babies when we diagnose the vein of Galen aneurysm, especially during the antenatal surveillance. And when again we go for this series, and for this series we go for the fetal neonatal outcome, as you see here, the 36.7% of all the series of the babies were alive and well. And the 52.9% of the pregnancies which did not terminate their pregnancies had alive and well babies. 30% of the families opted for the late termination of pregnancy. And the ones around the ongoing pregnancies, the 32% had neonatal deaths. So we can say the 1/3 of them are alive and well. 1/3 of them die in the neonatal period. And 1/3 of the pregnancies go for pregnancy termination. So the prognosis, in fact, is not so bad or is not so good. We should discuss these figures with our patients when giving counseling after the diagnosis of the vein of Galen aneurysm. And in this study, the prenatal variables associated with poor outcome were the straight sinus dilatation, the volume, if you have the chance to measure the volume, if the volume goes over 20,000 millimeter cubes, the prognosis gets worse. If the baby has tricuspid regurgitation again, the outcome is expected to be worse. So the babies should be followed up with these markers during the every week scan after diagnosis of vein of Galen aneurysm. And the other topics, the cysts and the hemorrhages, again, some good papers from Israel, around 47 patients referred to a fetal medicine unit for a fetal neurological examination. This study has revealed that most of the anomalies diagnosed in the 3rd trimester were the intracranial cysts. As you see here, 19% were the intracranial cysts in the babies with neurological abnormalities presenting in the 3rd trimester. And the intracerebral hemorrhage was again among the 4 most common anomalies found in the 3rd trimester with a frequency of 10%. So intracranial cysts and tumors, we have lots of them. I won't go through all of them, of course, but the arachnoid cyst important. It's seen in very frequently, 1 in 100 births, but only 1% are large enough to be dissected prenatally. The most important diagnostic sign is they are mostly unilocular and they are avascular cysts. And the most important, again, point is they are not communicating with the lateral ventricles. If there is any communication, you should be suspicious of any cleft or any porencephalic cysts. There should be no communication with the lateral ventricles. They are usually found in the midline between the cerebral hemispheres in 90%, but 10% may also present in the posterior fossa behind the worms. The prognosis for isolated small cysts is really very good. We expect normal neurodevelopment. But if the cyst is enlarging and if it's compressing, these babies may develop hydrocephalus, and surgery may be required after birth for prevention of the long-term sequelae, including the seizures, headache, motor deficits, and neurodevelopmental delay. And in the follow-up, we make the fetal detailed examination. Also, again, we add the neurosonography to exclude other features. And fetal brain MRI may be useful if ultrasound suggests the presence of other abnormalities. The ultrasound scans every 4 weeks is enough to monitor the size of the size of the cyst, causing possible compression resulting in ventriculomegaly. And usually, again, we prefer to deliver these babies around 38 weeks. Brain teratoma is very, very rare, 1 in 1 million births, but it's the most common fetal brain tumor. You see an irregular solid mass with or without cystic components. But if you see it, its prognosis is very bad. Around 90% of the babies are lost after birth or in utero. As I said before, the fetal intracranial hemorrhage is one of the most commonly diagnosed problems during the third trimester of brain problems in the baby. The incidence is in fact unclear, but estimate is thought to be around 1 in 10,000. We know that intracranial hemorrhage is a common event in the premature infants, and we know the factors predisposing to in utero intracranial hemorrhage. The most prominent factors are the maternal trauma or the fetal coagulation disorders, but more than 50% of the cases, most of the time, the cause is unfortunately stays unidentified. So how we see these on the ultrasound? We can see, a very fresh hematoma, very fresh blood on the ultrasound, very hyperechogenic. And as the pregnancy goes on, as the hemorrhage becomes old, you get some cyst formation inside the hematoma, and it becomes hypoechogenic in the center, and it becomes hyperechogenic at the borders. And also you see the ventricular margins to be hyperechogenic following an intracranial hemorrhage. And after the intracranial hemorrhage, there may be spontaneous resolution, or sometimes the blood clot may obstruct the CSF system, and it may result in ventriculomegaly. So these babies should be kept under close surveillance if ventriculomegaly is anxious or not. And sometimes we may also see some hemorrhage in the infratentorial lesion in the cerebellum, which have usually a worse prognosis. And as the pregnancy proceeds, you may see the development of a porencephalic cyst on the ultrasound. The porencephalic cysts are usually seen in 1 in 10,000 births. Usually you see one or multiple cystic lesions in the brain. The most important point in this porencephalic cyst is that they communicate with the ventricles, the subarachnoid space, or both. There are some types of it, but I won't go into the details, but they are most commonly associated with hemorrhage or ischemia, or sometimes they may be associated with the malformations of the cortical development. So how we follow up them, and what is the prognosis in these babies? The hemorrhages most commonly occur in the cerebral ventricles, but sometimes they may also occur in the subdural space. If the mother has trauma, the subdural space is much more commonly seen in the maternal hemorrhage, maternal trauma cases, and also they may be seen in the infratentorial fossa. The outcome, according to, again, a very good large trial from 2003 in the White Journal, says us that about 40% of the fetuses die either in utero or within the first month after birth if they have intracranial hemorrhage. And among the survivors, less than half of them appear neurodevelopmentally normal at short-term follow-up. What are the prognostic factors? A slightly better outcome with the subdural hematomas when compared with the intracerebral hemorrhages. And the grade is important. If you have a high grade of hemorrhage, the outcome is worse. And my final 2 or 3 slides, what about the patterns of fetal hypoxic ischemic brain injuries? There are different patterns of involvement depending on the severity and the time of the insult. We may, any neonatal, fetal hypoxic ischemic brain injury may result in hydranencephaly and porencephaly, or periventricular hemorrhage, or periventricular leukomalacia. If the baby experiences this hemorrhage or this hypoxia or ischemia before 28 weeks, since the immature brain is not able to react with gliosis, the brain parenchyma gets liquefied and the CSF spaces get enlarged. So we see most of the time hydranencephaly or porencephaly if it occurs before 28 weeks. As you see, this is the MRI. There is no brain tissue here. That's just the liquid there. And between the 28 to 32 weeks, usually we see the periventricular or intraventricular hemorrhage. And after you go to the 32 to 36 weeks, this hemorrhage or this ischemia, hypoxia causes bilateral necrosis within the white matter. And this white matter loss is associated with gliosis and cavitated lesions adjacent to the lateral ventricles. So it results in diffuse white matter injury and also causes the hypomyelination. So this is, in fact, the continuous disease spectrum with the subcortical leukomalacia, which is mostly diagnosed in the premature infants after birth. And periventricular leukomalacia is known to be one of the major causes of cerebral palsies, and they are frequently found in premature infants, and that of a co-twin in the monochorionic twins. The most important differential diagnosis is between the periventricular pseudocysts. Periventricular pseudocysts are very frequently diagnosed in the premature newborns that undergo brain sonography during the 24 hours of life. The prevalence of the periventricular pseudocysts in fetal life is not known, but the most extensive series again comes from Mallinger. They are most commonly diagnosed around 30 weeks of gestation. They are again typically like the periventricular leukomalacia. They are located around the ventricles, especially lateral to the wall of the frontal horn of the lateral ventricle. They are thought to develop antenatally due to germinal matrix hemorrhage or small infarct. But the point is that if they are isolated, these isolated pseudocysts usually have good prognosis and outcome. So the differential diagnosis is important, especially if you suspect of any periventricular leukomalacia or the isolated pseudocysts. So I really appreciate your patience with my technical problems, and I would like to invite you all on site and our online ultrasound course in September in Bodrum, Turkey. Thank you again very much for your attention and patience.